Thank you for the invitation to speak today at the Mellinkoff GI Symposium. Today I'm going to be talking about why it's important to study these rare lumps and bumps that we find. I'm specifically going to be focusing on gastrointestinal stromal tumors, or GISTs. Although they are rare tumors, they really have led the way, or the success in treatment of these tumors has really led the way in the targeted therapy evolution or revolution that's occurring in medical oncology. Understanding the driving mutations in these tumors and how to treat them specifically really does help the physician manage these patients, assess their risks, and whether or not they can be treated and how to treat them. And that will definitely improve your management of these patients. So just a little background: sarcomas are rare tumors. They make up less than 1% of solid tumors in adults. They're actually the third or fourth most common solid tumor in children. They are aggressive. There is a broad range of aggressiveness, as there is in GIST with sarcoma. The difficult part about sarcomas is that there's over 80 different histologic subtypes of sarcomas. There's 50 different histologic subtypes of soft tissue sarcomas. If you, this is soft tissue sarcomas. Liposarcoma is the most common soft tissue sarcoma. Actually, GIST is probably close to the second most common type of soft tissue sarcoma, followed by leiomyosarcoma, and MFH is a diagnosis that does not exist anymore. This is a mixture of fibrosarcoma, myxofibrosarcoma, malignant peripheral nerve sheath tumors, and the likes. But they're difficult for a pathologist who doesn't have a lot of experience in these tumors. They all behave differently. They respond to therapies differently. They really are different malignancies. So the exact incidence of GIST is not known. It seems to be rising, primarily due to the identification of c-KIT, understanding of the molecular events driving these tumors, and the success of imatinib in terms of the treatments. They originate from the interstitial cells of Cajal, GI pacemaker cells. They peak incidence is in the 6th and 7th decade of life, although they can occur at almost any age range. They tend not to occur in children, other than some rare instances. Just like sarcomas make up less than 1% of solid tumors in adults, GIST make up less than 1% of GI tumors. They, as you are all probably aware, they can occur almost anywhere in the GI tract. Most common location is the stomach, followed by the small intestines, rectum, colon, and esophagus. They can occasionally arise in the mesentery, although in those circumstances it's unclear if it's just an extension from the wall of an adjacent bowel. They tend to be large tumors. The ones I see are quite large, much bigger than a typical carcinoma. They arise in the wall of the bowel. They can have a very large extension outside of the bowel, and they may or may not have ulceration of the mucosa, but they can be dramatically large, and you'll see that in a minute. Unlike carcinomas that tend to kind of grow and invade, sarcomas in general, and it's also true of GIST, they tend to grow and push adjacent organs, which is useful operatively, and why these tumors can get so big and still be resectable. They're defined by immunohistochemistry as being CD117 positive or KIT positive. They're also CD34 positive in a majority of cases. They occasionally stain for smooth muscle actin and rarely stain for S100 or Desmin, and this helps differentiate them from GI leiomyosarcomas. Just a comment on the kit staining. The kit staining is uniform and diffuse. Lots of tumors can have spotty staining for kit. It doesn't mean it's a GIST. It has a characteristic staining that's quite diagnostic in its staining. There are some new markers that are used for GIST that you'll probably start to see. They're markers for platelet-derived growth factor receptor alpha. DOG1 is the one that you'll see the most frequently. PKC is another one as well. This is one of the other driving tyrosine kinases that gets mutated in GIST that can drive this disease. So this is a typical panel of a gastrointestinal stromal tumor. So one of the central questions for gastroenterologists and physicians in general and surgeons is this a malignant GIST? And if it is malignant, how malignant is it? Does it need to be resected? Does it need to be treated? And the like. There's a number of prognostic factors for these tumors that help you decide this. By far and away, the most important factor is the number of mitoses per high power field, or the mitotic rate. Size is also a predictive factor as well. It tends to be more a byproduct of the high mitotic rate, but larger tumors tend to do worse, which is not a surprise. This is a busy slide, but if you look at the area that's in the red box, this is all tumors based size and different locations, gastric, duodenum, and the like, with greater than 5 per 50 high power field, mitoses per high power field. Basically, if you have greater than 5 mitoses per 50 high power field, you have a high risk GIST. There's lots of caveats to that. You can have a small gastric GIST so less than 5 centimeters with a high mitotic rate, but it still has a mortality of 16% associated with that. So that's as low risk as you get in that category. So basically, mitoses per high power field by far and away trumps all the other values in terms of predicting its malignancy. And the way that you assess that typically is by getting a core biopsy. An FNA, really, they have a difficult time giving you an assessment of mitotic rate. And for sarcomas of other sites, that's our standard in terms of obtaining histologic diagnosis. It's obviously difficult in certain circumstances with GIST, but understanding the importance of this helps you in terms of how you biopsy these tumors. This is another way to look at it. Very low risk, small size, less than 5 per 50 high power field of mitoses. Intermediate risks, tumor, small tumors. Once you get over the 5 per 50 high power field, you start to automatically get into the intermediate risk, even with the small tumors. And then large tumors and high mitotic rates, obviously high risk tumors. This is some slides indicating how significant the mitotic rate is at predicting the outcome. This is some data at Sloan Kettering when I was there. And this is in the pre-Gleevec era. And it's progression-free survival. This is greater than 5 mitoses per 50 high power field compared to less. So a significant difference. And if you look on multivariate analysis, there's an 11-fold increase in the hazard ratio. The second most important prognostic factor is tumor size, followed by site. Stomach just do better than small intestine or colon. They tend to do worse. So this is something called a nomogram. They are being used a lot in surgical oncology and medical oncology. The AJCC staging system really does not work well for sarcomas at all. They don't go to lymph nodes. There's so many different histologic subtypes, and there's a lot of variables that predict our outcome. And they've developed nomograms really based off the large data set originally at Sloan Kettering for sarcomas, and then off our data set at UCLA for the various histologic subtypes. And what it does is it integrates the various prognostic characteristics of an individual patient and gives a progression-free survival prediction for the individual patient. And it's useful for the clinician to assess the risk profile of these patients. So as an example, we'll take a 56-year-old male with a 9-centimeter gastric cyst with 7 mitoses per high-power field. So 7 centimeters, he gets 50 points. Greater than 5 mitoses per 50 high-power field, he gets 80. Stomach, he gets 0. So he gets 130 points. And what that means is he's got a 30%, at 2 years, he's got a recurrence-free survival of only 30%. And at 5 years, he's got a 10% recurrence-free survival. So it's a very high-risk tumor. They have developed these for other malignancies as well, and the usefulness is being debated. But at least for sarcoma, they're much more accurate and amenable to use by patients than the AJCC staging system. I'm not going to talk too much about, although I am a surgeon, I'm not going to talk too much about the surgical treatment of these tumors. The treatment is, the only way to cure these patients is to remove the tumor. The surgical principles are that for most malignancies, although they are a little different. You need to resect the complete tumor. Unlike gastric cancer, you just need to take the tumor out with a negative margin. You don't need to do a distal gastrectomy. You can do a wedge resection. You do need to achieve a negative margin. As I mentioned, they tend to grow and push other organs. Just because it's touching it doesn't mean you have to resect it. And we do not do lymphadenectomies for GISTs or other sarcomas. There are some rare subtypes that can go to lymph nodes, but as a whole, the sarcomas don't go to lymph nodes, and it's really irrelevant for our care. One important point, though, in terms of the surgical management, they tend to be very vascular, bloody tumors. They are prone to rupture. There's a number of surgeons who like to take these out laparoscopically. I think that's probably okay for a low-risk GIST, if you can convince yourself of that. The higher-risk GISTs with high mitotic rates tend to be very fragile tumors. You can convert a curable patient into an incurable patient by rupturing that tumor. So the overall goal is obviously to take it out completely without rupture. And the other, I'll talk about it later, that speaks to the role of neoadjuvant therapy, particularly with imatinib. These tumors respond dramatically to treatment. They scar down and are much less fragile, and operatively they're much easier to take out. And obviously you should assess the abdomen for metastatic disease at the time. Most common site of metastasis is the liver, and they tend to spread within the peritoneum. Before Gleevec came out in around 2000, we actually had a trial of giving intraperitoneal chemotherapy for sarcomatosis because they get a diffuse sarcomatous pattern. Fortunately, Gleevec came out at that time, and we were able to change that trial to one of a targeted drug. So the main focus of the talk is going to be on the importance of understanding the oncologic events in these tumors and how that's relevant to you, the patient, and their outcomes. So c-KIT was described by Hirota et al. From Japan, and this is a paper in Science that was published in 1989, where he described this c-KIT as the driving mutation. Mutation in the c-KIT tyrosine kinase is the driving mutation for these tumors. The mutation can occur at different locations within the tyrosine kinase, and I'll talk about that at different exons. But what happens is it becomes constitutively activated, and the flip is switched on, basically, and these tumors go. It is quite interesting. This is looking at articles on GIST and PubMed, the explosion of publications with the understanding of the oncologic event and its subsequent treatment. A lot of things happened to coincide to have such a success. So, about 70% of GISTs have mutations in KIT. About 10% have mutations in platelet-derived growth factor alpha, and up to 18% are wild type. So not all GISTs are driven by the KIT mutation. It is the most common. Within the KIT, if it is a KIT mutated GIST, the most common mutation is in exon 11. So about 60% of GISTs have a mutation in exon 11. The next most common is exon 9, followed by the other exons. And then you can see which exons within the PDGFRA or alpha that arise as well. These are important for a number of reasons that I'll talk about. So ideally, you would not only know that this is a KIT mutated GIST, but you would know which exon the mutation is in. And it's almost a standard of care to know that at this time. So Hirota identified KIT as the driving mutation in GIST in 1998. Gleevec was approved for CML in 2001, based on a lot of work by Charles Sawyer, who was here, now is at Sloan Kettering. It just so happens that imatinib blocks KIT in addition to the BCR-ABL. And so the first patient, this is well, relatively famous, I guess if you're a sarcoma doctor, it's famous, publication or case report in the New England Journal. It's the first patient treated with GIST. It was a patient with widely metastatic disease who'd failed the typical regimens of sarcoma therapy, had multiple surgeries and the like, was put on imatinib at a dose of 400 a day and had a dramatic metabolic response that was durable, and the size changes also gradually shrunk as well. The preclinical models all supported the use of this drug in patients, and at least for sarcoma, a miraculous trial was done because these are so rare, these tumors in general. And this is the first trial, and this is for patients with advanced GIST. They got a dose of Gleevec at 400 once a day, 400 twice a day, so 800 of Gleevec, and versus the standard of care chemotherapy at the time. And there was a dramatic improvement in their outcome. So this clearly proved that imatinib was the drug of choice in these patients, and as you probably know, it's a very tolerable, it's oral, very minimal side effects, some edema, periorbital edema and the like, but relative to the systemic treatments that were used for sarcomas, it was a breakthrough. There was a number of other trials done in Europe and other places. This one was in Boston, looking at different doses for patients with advanced disease, and it becomes important because it gets tied into the mutational status. So this was looking at 400 versus 600, and there was no difference, as you can see, in the survival. This was one looking at 400 versus 800, and remember the first trial was looking at 400 versus 800 as well. So what was done is, while they were doing these trials, is they were doing mutational analysis on all these tumors. And they did a meta-analysis of all the studies looking at mutational status and response to Gleevec in patients with advanced disease. And what was found that, this is the main point that came out from it, patients with exon 9 mutation really don't respond or marginally respond to a dose of 400. If you give an exon 9 a mutated GIST a dose of 800, they respond similar to an exon 11 treated with 400. So exon 9 mutated GIST need a dose of 800 to adequately treat them. So they did a number of studies for advanced disease, proving that Gleevec is the dream drug for these patients. They identified some dosing based on mutational status. The next big trial that was done was through the American College of Surgeons Oncology Group, and it was an adjuvant trial for high-risk primary disease. And I don't go into the study much, but needless to say that patients with high-risk GIST who had a significant improvement in outcome with adjuvant imatinib compared to those who did not. It's kind of a silly trial. We knew the results. One of the important things that came out of that trial, though, was the mutational status in general is important in terms of predicting their outcome. So in the post-Gleevec era, one of the most important prognostic factors beyond tumor size and this, that, the other thing is which exon mutation they have. So advanced disease was done, adjuvant treatment for high-risk primaries was done. One of the questions that arose as the treatments have gone along is how long do you treat these patients? This is an interesting study from France where they took a cohort of patients, 430 patients who were on Gleevec therapy, and they took 50 patients at 3 years. And so all these patients had stable disease and were responding along. And they randomized them, one group to continue the drug and one group to get off it. And not a big surprise, patients who were taken off the drug rapidly did poorly. This is after 3 years of therapy with Gleevec. And interestingly, putting them back on, they still did poorly. So stopping the therapy was not a good thing to do. So in patients certainly with advanced disease, at this point, no oncologist will take them off it. And for high-risk primary disease, that's pretty much the similar recommendation. Now, I'm going to talk the last few minutes talking about neoadjuvant therapy. So advanced disease, adjuvant for primary, the next step obviously is to do neoadjuvant studies. This is an ideal drug to treat patients neoadjuvantly with. It's oral, it's very effective, and a number of things happen that make these tumors much more amenable to surgical resection. Beyond the normal rationale behind giving neoadjuvant therapy, you treat micrometastatic disease at presentation, you decrease the size of the tumor, which obviously can decrease the morbidity of the operation, decrease the extent of the organ that you have to take out, decrease the risk of needing to take multiple organs. And I can tell you operatively, it decreases the morbidity of the operations themselves. A high-risk cyst that's treated really scars down, is much less fragile and bloody. The blood loss from the operation is less, and it's really a much easier operation. There's a number of studies ongoing for this. There's one in Europe which never could be done here, where they're randomizing patients to Gleevec neoadjuvantly with surgery, and then one group's not even going to have surgery. They're just going on the Gleevec for a high-risk primary cyst. We'll see what happens with that. But the push and the data clearly is that for a high-risk cyst, at most major centers, patients will get treated in a neoadjuvant manner. So what does that mean based on what I've shown you? What it means is that to adequately do that, we need to know the mutational status of the tumor. In addition to knowing the mitotic rate to adequately risk stratify patients, we do need tissue to do mutational analysis because it's so important in terms of the dosing of the drug. As we talked about, KIT mutations are treated with imatinib. The only caveat in that is that exon 9 is treated with a dose of 800. As a whole, mutations in PDGFR alpha are resistant to Gleevec. The exon 12 and 14 in the PDGFR alpha are very rare, but they do respond to Gleevec, so you can do that. So if you had a patient that came in with a high-risk cyst and they had a PDGFR alpha mutation, really those patients should just go to surgery. They tend not to respond to all this, any of the second-line agents as well. Similar with wild-type there's a number of exciting new studies looking at various targeted agents for them, but for the most part, those patients should go to surgery as well. The final obvious point that by treating somebody neoadjuvantly is you get the answer in terms of whether the drug works or not. The tumor can give you that information as the clinical situation of the patient. Not everybody responds, even to Gleevec. There are rare cases, so you find out response data. This is a case presentation that we're going to talk about later, but these are 3 different patients. All of them have high-risk cysts. They're all in the stomach. They're all over 5 centimeters in size. Their mitotic rate's all over 50 per high power field. They would all benefit from being treated with Gleevec prior to surgery. So the question is, what do you need to know prior to doing that and how we do that? I talked about the standard of care in terms of getting tissue for sarcomas of other sites. We use an image-guided core biopsy. With a lot of the GI doctors here, I've been trying to talk them into doing core biopsies endoscopically, which they are intermittently amenable to. But if it is not, then they can do a CT or ultrasound-guided core as well. That's sufficient. So it doesn't have to be done endoscopically. In fact, this patient had an endoscopic diagnosis, but these 2 were both percutaneous cores. There is this risk of rupturing or seeding the tumor with the core needle biopsy or the like. I've never seen that. The other risk or argument I've run into with gastroenterologists in terms of not wanting to do neoadjuvant therapy is that the patient's bleeding. They tend not to bleed acutely. They tend to have an ooze. Even those patients will quickly stop once they respond to therapy. And I've seen patients with contrast going into the tumor. We've treated those as well. They don't rupture. They really tend to scar down. Obviously, we're around in the event that changes, but I've not seen tumor rupture. I've not seen problems with a biopsy, nor have the other institutions around. So I'm going to end it there, but I'm going to just want to highlight there's, just so you know, there's a number of very vocal support groups for GIST. And so what happens is a patient gets diagnosed with a disease and they go on Google and they get these support groups, and they are completely knowledgeable about mutational status, everything like that. And the patients will come in and they want to know the mutational status of their tumor. They want to know everything. So it's not, you have to know this information because the patients are going to know it if you don't. And it's amazing how vocal they are. And that's it. So we'll save questions for later unless people wanted to ask any questions now.